Hi, I will start with an apology that I got a chance to do a pediatric neuroradiology clinical fellowship last year in Hospital for Sick Children, Toronto, and some of these images are from there. And I've not been doing much of a neonatal imaging since I've returned because I'm basically working on an adult hospital. Soon we will be starting, I hope, really pediatric neonatal imaging. So this is a case which I had an opportunity to do when I was back from Canada. So this is a fetal MR imaging. When we talk about imaging of the young brains, we start with an unborn brain. So what is the role of fetal MR imaging of the brain? Because you can actually diagnose almost everything with ultrasonography, and ultrasonologists, fetal ultrasonologists are actually really good. They're doing a really great work. But there are problem cases where they will definitely be actually referring cases to us. And as a neuroradiologist, I think basically neuroradiologists should do fetal neuroimaging because we have a better concept about neuroanatomy and the developmental anatomy of the pediatric brain. So we should actually focus and do it on a 1.5 Tesla size seat today because it was never been tried on a 3 Tesla, although it was available in sick kids. But I know that there are people in Europe, they are doing it on 3 Tesla because I have specific concerns about the SAR effect, even though the machine says that is well within the SAR limit. The machine is actually talking about the mother's abdomen, not the fetal brain or the fetal cochlea. So we should be concerned at this moment till further evidence comes that 3T is really, really safe for fetal imaging, especially before 20 weeks of gestation. So we tend to do only on 1.5 Tesla even abroad. So this is a vein of Galen malformation. We can do a Hayes sequence. We can show these abnormal veins which are dilated and the arterial feeders, and also we can even run a 2D PC angiography to do these things. So some other cases from Dr. Blazer from sick kids. You can see the corpus callosal agenesis. Anybody has diagnosed on this case?
Dandy Walker.
No, it's not really Dandy Walker. You can see a posterior large CS of space, but a C-shaped brainstem, which is very characteristic of Walker-Warburg syndrome. It's a congenital muscular dystrophy. You can also see that the cortical abnormalities also will be present in these cases. All these things you can actually do within 20 minutes. You need to start with the localizer scans of the abdomen. You can actually say which side of the fetal abdomen corresponds to the mother's left or right, and you can actually give a very comprehensive report, which is very extensive in sick kids. So these are again some of the borrowed slides from Dr. Schroff because I don't have a clear-cut first-hand experience other than the fact that I've done a fellowship which I was doing all these things abroad. So we know that the signal-to-noise ratio is directly proportional and indirectly proportional to the cold radius, and it's actually when you are talking about neonatal MR imaging, you should have a 17 centimeter or less head coil, which is not readily available for most of us. Can we do it on a knee coil? Probably yes, but actually monitoring these patients in the knee coil will be very, very difficult, and also some of the sequences like iPad imaging or even SWA may not be available on a knee coil. So we need to have a dedicated head coil for neonatal imaging. What else you need for, we need to talk when they are really, really susceptible to environmental changes, and they are actually in a very protective environment, especially when we are talking about preterm infants, and when they are transported to a very hostile cold MR environment with a lot of RF energy being deposited, and also a very high magnetic field is being playing. So you have to be very, very careful about their general conditions. So how it can be optimally transported is possibly using an innated transport ventilator, which is MR compatible, with a head coil which is attached. But the problem is that this head coil which is attached to a neonatal ventilator, transport ventilator, is very expensive. It costs anything above $500,000 US, which may not be possible to be afforded in this part of the country, which will be more than most of the 1.5 Tesla MR images which is available in this country. So you can't afford to have that. But when you are actually transporting, you should be aware that they are actually prone for a very hostile MR environment. You have to limit your studies to the minimum possible time, and you should arrange for optimal transport, use of optimal coils, and optimized sequences. When we talk about sequences, these people, we can't sedate them quite often because of their clinical condition. So although there are most of the places outside they sedate them, but we can use sucrose pacifiers, but they will lie down for quite some time, for seconds. So you can actually finish off a diffusion sequence. It's the most important sequence in a neonatal imaging in an acute setup. Then you need to do a T1 optimized T1 weighted image, then a T2 weighted image, and if possible a 2D gradient echo image, which is a very fast gradient sequence we can do. So as optimization is concerned, all these things are done on another vendor's machine, but it's very well applicable more or less in Siemens, because if you're really planning to do neonatal imaging, you have to do a neonatal protocol. We can see that this is not the unoptimized routine T1 protocol. The TR is 420 in another machine, and the TR has to be increased and the T has to be increased because the neonatal brain T1 weighted T1 of the most of the structures are higher than normal elderly people and as well as older children. And T2 also, you should have a very high T2 weighting because the myelin water content is really high. So you can use up to a TR of 9,000 and a T of 250 if you are really talking about premature infants. Again, single voxel MR spectroscopy was the preferred technique in sick kids, because basically we are talking only about looking at the lactate or other metabolites which are of significance, so you don't need to have a global information. And when we talk about venography, it's quite often a problem. Venous sinus thrombosis is a real clinical problem, but we can't inject contrast in neonates because their JFR will be very, very low, and we don't know the long-term side effects of gadolinium. So we can use phase contrast angiography, which is very good for neonates because you can actually see these veins very well, just like a contrast enhanced MR angiography. So T1 is useful for looking at the posterior limb of the internal capsule. We call the plic, which is, if it is lost, it really suggests that the neonatal hypoxia has happened. Also, it is good in actually detecting microhemorrhages versus ischemic focus, and also periventricular hemorrhagic and intraventricular hemorrhages. T2 is good for looking at how the diffusion, the T2 hyperintensity changes of the thalamus as well as the basal ganglia, and also look at the diffuse extensive hyperintense signal intensity, which is a part of hypoxic ischemic insult. So coming to spectroscopy also, when we are talking about spectroscopy of the neonates, they have a different spectrum. They are up to the age of 2.5 years, their choline can be higher a peak than compared to NA. So you should not interpret that this is actually abnormal. So after the age of 2.5 years, their NA builds up because their myelin matures and the neurons mature, and I can actually see the NA building up. So this particular late childhood or adult pattern may be obtained only after 2.5 years of age. More important is actually looking at a lactate peak, because there are papers which suggest that if lactate is there, they suggest a severe hypoxic injury and the prognosis may not be good. But also the caveat, you should understand that small amount of lactate is normally present in newborn infants, especially when they are preterm. Another very extensive, very important thing you should do in a neonate is that we can do, and especially when you are suspecting hypoxic ischemic injury, is that you can do a coronal diffusion. Look at this super scan. When there is global diffusion restriction, you will tend to ignore it because your eye will always look for a contrast. But coronal diffusion can see that the cerebellar diffusion is much less than the supratentorial diffusion is actually much less than cerebellar diffusion. There is diffuse diffusion restriction. This is comparable to a nuclear medicine super scan. This suggests that there is significant hypoxic damage to the neonatal brain. So it is a very important technique you can actually do in neonates, especially when you are talking about this. Compared to that, the coronal SWI is not a good option to do, because SWI, as you know, that is actually optimized in axial plane. You can see if you do a coronal SWI, you can see that the face of the basilar arteries, which is supposed to be bright, changes to negative veins, and almost all the veins in the cortical area disappear. So especially because it's a complex processing methods involved in the ultimate image contrast, so you should not do a coronal or sagittal SWI as it stands today. So when they develop the coronal or sagittal SWI, we can even be able to do that when they offer these correction factors. To end-stage PVL, we can do diffusion tensor imaging to look at the corticospinal damage. Kesh was already told about Wallerian degeneration, and their quantification may be useful for their prognostication as well as designing their physiotherapical rehabilitation. Another important thing you can look at is that the sagittal imaging, look at how much of corpus callosum is damaged. By looking at a simple gracile corpus callosum, we can actually predict the damage. So especially when there is a posterior limb of the posterior part of the body as well as the splenium of the corpus callosum is affected, you can that these patients present with more of motor deficits rather than cognitive outcome. You have probably seen that some of these hypoxic ischemic damage affect predominantly the genu as well as the anterior part of the body of the corpus callosum. These people will have more of cognitive bad outcome. And there are corpus callosal morphometric studies which looks at only the shape changes of the corpus callosum and predicting the patient's outcome. So even a sagittal gracile corpus callosum and writing where exactly the atrophy of the corpus callosum may be clinically important. Why this happens is that the interhemispheric inhibitory fibers of the motor tracts pass through the posterior part of the body. That's why when there is a hypoxic ischemic injury, most of the time you get the posterior part of the corpus callosum which is getting thinned out. Again, coming back to neonatal imaging, this is a paper we have published from sick kids on childhood epilepsy due to inborn errors of metabolism. Series of cases I can show you. Diffusion is a very important technique to differentiate between hypoxic injury or hypoglycemic injury. Most of the time they coexist, but hypoglycemic injury, there will be usually more posterior occipital cortical involvement rather than the basal ganglia and the posterior limb of the internal capsular involvement. So this is hypoglycemia can occur in neonatal, non-ketotic hypoglycemia can occur in a lot of conditions including spontaneous and also a lot of metabolic errors. Again, another condition called hyperglycinemia. Keshav has already told you how to differentiate between glycine and myoinositol. Coronal diffusion is also look handy in these cases. I'm talking about different sequences, different sequence optimization, which is possible in young brain. It's no way a complete list, and actually some of you might have more experience than me in neonatal imaging. So this is a coronal diffusion with the corticospinal tract is showing acute diffusion restriction, and also you can see that the dentate nucleus and the white matter of the cerebellum showing diffusion restriction. One of the differential diagnoses in a floppy neonate is neonatal hyperglycinemia. So how you differentiate between myoinositol and glycine? Glycine and myoinositol precess almost at the level of 3.56 or 3.6. In a 1.5 Tesla MR image, you are not going to differentiate between glycine and myoinositol if you do only one sequence. So this is how you do that. Myoinositol has got a shorter T2 relaxation time than glycine. So what happens if you increase the T? So in 31, both myoinositol, which is a normal component in a neonatal brain or a brain, both myoinositol and glycine will show a high peak at 3.56 to 6. But when you do 144, you can see that the myoinositol peak, if it were due to myoinositol, it would actually come down because it has got a shorter T2 relaxation time. But in this case, you can see that in the left basal ganglia, there is a peak which is persisting after doing 144 from 30. You can see that this peak is persisting, and this is due to glycine. And this is how you differentiate between myoinositol and glycine. It's very well described in Tortori Donati's book, which is written by Salt and Pate. You can also see lactate there.